And just a couple of reminders, please mute your line if you're not speaking, but please don't mute my FSSA line. Again, that makes us really sad when people do that. When we get to public comment, we'll make sure that everybody gets their chance at public comment. You can either shoot a message in the chat box, raise your hand. If you're in the room, we have a sign-up sheet, but we'll make sure your public comment gets captured. Also, as a reminder, we are doing roll call voting. So when we get to that point, I'll go through, you can do aye, nay, or abstain. And I will defer to Dr. Marshall as we move through the agenda, just to keep us on track and keep us moving as we go forward. All right, with that, I think I will get us started, and we will start with the call to order and remarks of the chair. Dr. Marshall.
No, I have no remarks. Thanks for joining, Dr. Class.
All right, then. Next up, we have opening comments from OMPP. Ms. Lugo.
Morning, everybody. Not much for this meeting today. Next month will be busy because we are working on the DUR annual report, so we'll have those for you next month. And with Pathway starting in July, we'll go over that program and introduce you to the new MCEs. Two are not new, one is. So we'll do that in June. So a couple busy months coming up.
Thank you. All right, that takes us to the approval of the minutes then. If I could get a motion a second, or any questions or comments on the minutes from last month.
This is Petra. I move to approve.
Drew, second.
All right.
It's been moved in second, Amanda.
Thank you. Dr. Marshall.
Aye.
Dr. Class.
Aye.
Ms. Pippin.
Aye.
Dr. Ott.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Abstain. I wasn't here.
Okay. Yeah. All right, so we have all ayes and one abstention, so that motion will pass. And we will move on then to our call center statistics. So PA stats for March of 2024. Overall, we had 71% approved and 29% denied. We were just shy of 20,000 approved and just shy of 8,000 denied. And when we look at our, so you might notice the new naming, we historically called it Silent Auth. They've renamed it to Point of Sale Quick Check. No, that was not a name any of us here chose, nor would it be a name we would choose, but we'll try and muddle through with the new name. But if you hear me use Silent Auth, it's the same thing. So on the point of sale quick check side, we had 74% approved and 26% denied. Of those denied, 22% went to the call center, where 79% were approved and 21% were denied. On the manual PA side, we had 59% approved and 41% denied. When you look at our overall trending graph, really pretty steady over the past kind of several months here. So really pretty leveled out and fairly consistent with what we've been seeing. When we look at the top 10 within the point of sale quick check, stimulants, opioids, antipsychotics in the top 3. So no real big changes there about what we've been seeing. Still having some shortages and outages of the stimulants, and just kind of depends on the product at any given moment. So we do still see some changes there and approvals there. On the manual PA side, we had early refills in the top position, quite a significant position actually, and then beta adrenergics and corticosteroids and laxative and cathartics. The early refills, we did, I think, see a little bit of a spike due to spring break. So we have spring break time, and we saw some vacation early refills, as well as you might remember, we had some tornadoes that went through Indiana. And so we might have had some early refills for those as well, as part of the disaster kind of recovery event, so to speak. So not really surprising there either. Any questions or concerns before we move on to the opioid stats? All right, so for March, we did have a slight decrease of the total utilizers, but a little bit of an increase of new utilizers, and that does seem to kind of go back and forth just depending on where we're at any given time, but not a substantial change. Children under 18 are still holding in around the 4.4 days and staying fairly consistent there. You can see the breakdown of the 90 MME and higher, and then where everybody kind of falls on the PA exempt side. So you'll notice that everybody in the 500 and above is PA exempt. So we're down into the kind of under 500 group now, as far as those that may not be PA exempt that we're working through PA on. So here's just kind of showing that in graphical formation. Just a reminder, the less than 90 isn't here since it's so large. So we've got the 90 to 120 on the far left. And then again, nobody's falling into that 500 and above. When we look at our overall trending, again, overall fairly steady. You'll see just like a slight decrease again overall, but these past few months have been kind of fairly consistent. We were, kind of on that upward trend, and I feel like we kind of went down just a smidge, and we've kind of been hanging around there fairly consistently over the last kind of several months. Here's our less than 90 trending. So again, fairly steady. And then when we look at our other group, fairly steady as well. Again, just a reminder, the 500 and above, they're going to be, fairly flat because it's those individuals that are PA exempt. And then in the 250 to less than 500, you do see that going down just a little bit because we are moving people down. And then you do see just a slight uptick in the 200 to 250. So again, we're moving people down in the way we would want to move them down in their doses. So no surprises here on the graph, and exactly what we would expect to see at this point in time. Any questions on that before I turn it over to Anne? All right.
Thank you. Good morning. My name is Ann Kuhn. I'm one of the pharmacists with OMPP, and it is time for our MME reduction 6-month check-in. 2 years ago, in April of 2022, as part of the Support Act requirements, IHCP updated opioid utilization criteria to include a maximum allowable daily morphine milligram equivalent, or MME. During that approval, the DUR board had requested periodic updates. The last update was performed in October. So today we're wanting to provide data from the fourth quarter of 2023 and the first quarter of 2021. So on October 1st, 2023, the MME limit was reduced from 625 to 575 MME. This table includes the number of members newly affected by the 575 MME limit, and of the newly affected members, those that had an exclusionary diagnosis. So just as a reminder, those diagnoses are cancer, sickle cell disease, or other terminal illness associated with pain, and includes palliative care. The number of prior authorizations submitted for the quarter has also been included in the table, along with the resulting approvals and denials. For all plans, there was a total of 23 members newly affected by the 575 MME, of which 9 had an exclusionary diagnosis. 16 prior authorizations were submitted, 14 for Anthem and 2 for fee-for-service. 11 of the 16 prior authorizations were approved, and we had 5 PA denials. So for the approved prior authorizations, the provider either proposed an alternative taper plan or provided documentation of a recent taper attempt. Additionally, oftentimes, an exclusionary diagnosis is identified during the PA process that was maybe not previously on the member's profile. Next. And then here we have a graph representing the members affected by the 575 MME limit, including those members that had a diagnosis of exclusion, and then just a visual of the prior authorization submissions for the quarter during the 575 MME reduction period. The next table includes values of the total number of members newly affected by the reduction that took place on January 1st to 525 MME. For all plans, there was a total of 22 members newly affected, of which 9 had an exclusionary diagnosis. There were a total of 13 prior authorizations submitted across the plans, 12 for Anthem, 1 for MHS, 6 of which were approved and 7 denied. And then here's the visual of the members newly affected by the MME limit when it was reduced to 525, and then just a visual of the prior authorization data for quarter 1, 2024. And then just as a reminder, and kind of also to help preface the next slide, the CDC updated the clinical practice guideline for prescribing opioids for pain. And in this update, conversion factor adjustments were made to some opioid agents. At our July 2023 meeting, the board did approve to adopt the CDC's updated conversion factors for the agents listed here. And then for the last slide, we have the members affected each quarter from all IHCP plans. And as you can see noted on the slide, there have been a total of 166 members affected by the MME daily limit utilization criteria over the past 2 years. So we had originally anticipated an increase in the number of affected members with each reduction, and we're still not really seeing that in the data. And then also to note, we had a large decline for Q3 2023. That was the 625 MME reduction, likely due to that implementation of those new conversion factors. So with the previous conversion factors, methadone at doses greater than 60 milligram per day had a conversion factor of 12. So now it's been updated to a flat 4.7. So we had some members that previously exceeded the limit now drop below. So, are there any questions? Awesome, thank you.
Thanks,
Thank
Ian. All right, next up, you should have received a Dear Doctor letter as well as a newsletter for our retro DUR proposal around the use of GLP-1s and SGLT inhibitors in patients, we have it just SGLT inhibitors. Any questions, comments, updates on either of those?
I thought it was very well put together.
Thank you. We appreciate that feedback.
I agree. I just have one question, if I could. In the newsletter, would it be possible to add a table for easy reference for the providers of the SGLT1s and the SGLTs and GLP-1?
Yeah, we can do that, of the products that are available.
Yes, please.
Any other comments? All right, if we could get a motion and a second for the Dear Doctor letter in the newsletter with the update of placing a table of the available products in the newsletter, we would appreciate it. We will get that going.
Move to approve.
This is Carol. I'll move to approve.
This is Kelly.
All right, thank you. I will go to voting then. Dr. Marshall.
Aye.
Dr. Klass.
Aye.
Dr. Ott.
Aye.
Ms. Pippin, I didn't mean to skip you.
Aye.
Dr. Treadwell.
Aye.
Dr. Williams.
Aye.
Thank you. We have all ayes, so that motion will carry. Appreciate it. We will then move on into the managed care updates. And I believe, Brian, you're going to be presenting again the combined slides?
Yeah, this is Brian with MD Wise. If you will all suffer through my voice, I'll do my best. Can you hear me okay?
Yes, we can.
All right. Good morning, everyone. So we're looking at the combined normalized PA approval rates. This first slide is the HIP graph, and nothing real concerning here. Just want to point out the couple of sort of trend from July, August, September, which was the first round of increases in PA requests related to the single PDL, and then the more significant October, November, December piece that you see after the grandfathering portion of the single PDL moved over. So you see those trends. The first one is a band for that quarter. It went back down to normal. The second one, that band that was the post grandfathering, and it's come back down to normal, just about the same baseline as what it was pre-single PDL. So that looks like we've made it through that hurdle and gotten that cleaned up pretty well. The next slide, please. This is HCC. We see this that same sort of quarterly peaks and falls in that July, September, October to December timeframe. Again, related to the single PDL. Nothing of concern here, nothing in the trend or anything that we see that's concerning. So overall, we continue to see that sort of slow decline back down to normal. And last but not least is the Hoosier Healthwise one. And again, we'll point out this one, you don't see it as dramatically. It is there, especially in that October to December. But keep in mind that scale on the left with the number of PAs per 1,000 members is really, really small in the Hoosier Healthwise population. So there's not many of these, and a small fluctuation could make the graph look a little goofy. So any questions on those? Okay, and then for the opioid claims, again, not much we see here. We continue to see that sort of slow decline. That's sort of consistent with what you've seen in the Optum data earlier this morning. Just that slow, steady reduction as we work to push down those MME levels across the HIP population. And then on the HCC, the next slide, similar trends, just, nothing popping out here for us at all. And then on the Hoosier Healthwise, again, very, very small numbers, but that same sort of slow trend sort of shows that the work that we're all sort of doing collectively is improving this situation. It's not really the prescribed opiates. I think it's the street fentanyl that's the biggest concern for the world today. So any questions on those? Okay, thank you.
Thank you.
Thanks, Brian.
And yep, and so then as we look at the buprenorphine data for the MAT treatments, just want to point out here on the claim side, not a lot of swing from the prior quarter to the current quarter. I did like to point out that row 2 there, the lime green, the buprenorphine naloxone sublingual tablet is still the lion's share for all the MCEs. There were some single PDL changes that took place at the bottom of this data, and what you'll see in the last couple of slides of this set is the uptick of the Sublocade Brixadi product lines with the injectables. And just remind everyone, they are the Sublocade is a preferred product, but both agents do require a PA, which you'll see in the subsequent slides, but nothing on the claims. The next slide, please. This is unique members, a similar situation. You're beginning to see that black portion of these graphs. On the next two, you'll see more of the black sections as those injectables start to gain some volume. Next slide, please. I don't know if it, so this is the unique prescribers. You begin to see that black band at the top of some of these bars start to show up as we've got prescribers that tend to use those injectables more so than the oral products. And so you see that little black band start to pop up on some of the plans here. That's what that's from. And the last one in this group is the PA requests. And clearly the black band here is new, and all of that is related to those injectable products. So it's not of concern. It is what we expected to see. So any questions on the buprenorphine data? Looking good, continues to stay on track to what we're expecting.
Thanks, Brian.
All right, thank you.
Any other updates from managed care? I'm looking at the folks in here and they're shaking their head no, so I'm saying they're globally answering for all of you. But speak now if you have something. All right, I am hearing none. So we will move on into new drugs then. We do have a new drug that we wanted to cover. You may have historically heard this referred to as NASH or NAFLD. They have now updated the acronym to MASH or MASLD. So MASH is now metabolic dysfunction associated steatohepatitis. And then MASLD is metabolic dysfunction associated steatotic liver disease. I feel like NASH was a little bit easier to say, but we're left with MASH and this. So new product Resdifra is now available for the treatment of MASH and MASLD. And so we would be looking for a diagnosis of MASH with moderate F2 to advanced F3 liver fibrosis confirmed by both of the following. So looking at one of the following tests being used to diagnose, whether that's FibroScan, liver biopsy, MRI, or one of the other tests to kind of go along with it. So FibroScan, core index, magnetic resonance elastography, enhanced liver fibrosis, and then the vibration-controlled transity elastography. So any one of those combinations kind of with the above. For the diagnoses, they should be 18 years of age and older. And then the prescriber attests that they do not have decompensated MASH cirrhosis. We would like this to be prescribed by or in consultation with an endocrinologist, gastroenterologist, or hepatologist. And then the dose does not exceed 100 milligrams per day. And then we have some max dosing of each strength. So 1 tablet per day of either the 60, 80, or 100.
Amanda, I'm a hepatologist and a gastroenterologist are pretty much the same thing, so I'm not sure you really need hepatologists there. And can I ask what the cost of this drug is?
Expensive.
Yeah, I mean, I'm sure it's expensive. You can ask. I don't actually know off the top of my head, but let's look. I can do a really quick pull up and get, yeah.
Van has a whack on it.
I'm not sure exactly what our cost to us is after. So this would be before rebate.
Yeah.
Usually they give an estimate. Let's see if I can find an estimate.
45,000 a year?
35,000 a year. 45,000 a year.
Oh my
But
goodness.
do keep in mind, historically, there has been no treatment for MASH. So we're probably going to see several more in the pipeline coming out for this treatment. So
Well,
historically,
I think the GLP-1s have shown improvement in MASH.
And
they have.
We
And we do have that in as right. It's not a labeled indication, it's in compendia for data. So we do have that included for use, but this is kind of the first drug to come out with an FDA labeled indication for that.
So if you wanted to take hepatologist out, I think you could make it easier.
I'm fine either way. I mean, we have it in there as or, so.
Right, but I think most doctors are going to say they're a gastroenterologist. You know, I just don't. Okay.
So you actually probably have a valid point, but we have always included hepatologist and gastroenterologist.
Okay.
Liver.
Okay. All righty.
It's
That's
one
fine.
of those things where we've always done it. So if we can go back and look at maybe if that's.
No, that's fine. It's not a big deal. But most people are going to say they're a gastroenterologist.
You're right. Yeah.
All right.
Some doctors prefer to just be referred to as a hepatologist rather than just a gastroenterologist.
Yeah. Well, no, you're right. Okay. All right.
Any other questions before we move on to the reauthorization? All right, so for the reauthorization criteria, just that the prescriber is providing documentation of clinical status, utilizing the tests we listed before. Again, this is just trying to show that the drug is actually working for this patient. And then again, that the prescriber attests that they haven't decompensated to MASH cirrhosis and that the member continues to have signs of MASH or some sort of contributing metabolic dysfunction factor. And then the same doses that I listed before. Any other questions on Rezdiffra? If not, if I could get a motion and a second for that, please, I would appreciate it.
Kelly, I move to approve.
I'll
This is Carol,
second if I can. Okay. Let
take
Carol
either of you.
second.
Well, it'll work. All right, Dr. Marshall,
Aye.
Dr. Klass, Ms. Pippin,
Aye.
Dr. Ott,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
And can I clarify, Dr. Class, did you say aye or nay? I was having a weird moment. Okay, thank you. We have all ayes then, so that motion will carry. I had a weird moment where I was like, did Dr. Class just say nay? So I wanted to make sure I capture that. All right. So next up, we have a liaison with other boards. Any liaison with other board discussion today? All right, I am hearing none, so that will take us to public comment. None signed up in the room, but if you are on the phone and wish to provide public comment, you can shoot me a message in the chat box or raise your hand, or just start speaking.
Hi, this is William Lamb from Magical Pharmaceuticals. Just curious, I see that you approved the prior authorization. Would you still like to hear the public testimony?
You are more than welcome to provide it. It's
Sure.
okay. I will, let me pull up my little timer here for you. Go ahead and get started and I'll get a timer out there for you in here in just a quick second.
Okay. Hello, my name is William Lamb, and I am a Health Systems Scientific Director for Magical Pharmaceuticals. Thank you for the opportunity to provide information on Rezdiffra. Rezdiffra is the first and only medication approved by the U.S. Food and Drug Administration for the treatment of NASH, non-alcoholic steatohepatitis. Rezdiffra is a thyroid hormone receptor beta agonist indicated in conjunction with diet and exercise for adults for the treatment of adults with NASH with moderate to advanced liver fibrosis, consistent with stages F2 and F3. This indication is approved under accelerated approval based on improvement of NASH and fibrosis. Continued approval for this indication may be contingent upon verification and description of clinical benefit in confirmatory trials. Avoid use of Rezdiffra in patients with decompensated cirrhosis. Rezdiffra is a partial agonist of the thyroid hormone receptor beta in the liver, which helps to reduce intrahepatic triglycerides. The efficacy of Rezdiffra was evaluated based on analysis at month 12 in a 54-month randomized double-blind placebo-controlled trial. Enrolled patients had metabolic risk factors and a baseline liver biopsy showing NASH with fibrosis stages 2 or 3 and a NAFLD activity score of at least 4. Efficacy determination was based on the effect of Rezdiffra on resolution of steatohepatitis without worsening of fibrosis, and one-stage improvement in fibrosis without worsening of steatohepatitis on post-baseline liver biopsies collected at month 12. Both the 80 and 100 milligram daily dosages of Rezdiffra demonstrated improvements on the histopathology endpoints compared to placebo. Monitor patients for hepatotoxicity, gallbladder-related adverse events, and drug interactions with certain statins. Most common adverse reactions that occurred in at least 5% of patients treated in either drug arm with Rezdiffra were diarrhea, nausea, pruritus, vomiting, constipation, abdominal pain, and dizziness. Diarrhea and nausea were the most common causes of treatment discontinuation. In closing, I'd like to thank the board for their time and consideration in allowing treatment-eligible patients access to Rezdiffra. I am available to address any questions.
Any questions today from the board? All right, thank you so much.
Thank you.
Any other public comment today? All right, I am hearing and seeing none, so we will go on then to old business. Any old business? I'm also hearing and seeing none. Any new business before I go into mine? All right. So first up under new business on the GLP-1 and combinations PA for Ozempic and Victoza, updating the indication terminology to metabolic dysfunction associated steatohepatitis, NASH, what we just talked about, and the MASLD for Ozempic and Victoza respectively. So having that indication. And then for Wegovy, you may have seen the recent headlines on their newest indication. And so Wegovy is the semaglutide that has been historically used for weight loss. It now has a new indication around cardiovascular disease, so we are looking at a PA criteria for that and adding that for authorization for use. So bear with me as we look through some of this. So the member should be 45 years of age or older, a diagnosis of cardiovascular disease in obese or overweight individuals who need risk reduction of major adverse cardiovascular events. We would be looking at a BMI of greater than or equal to 27, which is looking in their chart documentation. And then member has one of the following. So a prior MI, prior stroke, symptomatic peripheral artery disease as evidenced by one of the following. So amputation, history of peripheral artery revascularization procedure, or intermittent claudication that's listed there. And then also one of the following, that they've already been optimized on guideline directed therapy, which include beta blockers and or renin-angiotensin system inhibitors and lipid lowering agents, supported by a chart documentation or claims history. And then, or the provider has provided medical justification as to why they are not using those agents. And then the prescriber attests to all of the following, that the member does not have type 1 or type 2 diabetes. The member will use Wegovy in combination with a reduced calorie diet and increased physical activity. And the member will not use with the other semaglutide products or any other GLP-1 combination products. And then the dose requested does not exceed the 2.4 milligrams per week. Any questions on that? I know that was a lot we just went through before I go into the reauthorization. Okay. And then as far as their reauthorization, we would be looking for history of the requested agent for at least 90 days within the past 120, just to show that they are compliant. They still have the same diagnosis of cardiovascular disease in an overweight or obese individual with the need for risk reduction. Again, the same kind of attestations that they're not type 1 or type 2 diabetic. They're using it in combination with the reduced calorie diet, et cetera, what we already talked about. And then that they also continue to utilize their guideline directed therapy, or why they cannot utilize that, and that the dose is consistent. Any questions on Wegovy before I move on into our last bit? All right. Hepatitis B, agents PA, Venlity, updating the age indication to 6 years of age and older, and weight of at least 25 kilograms. So that's just an indication update. And then Fasenra, updating its age indication to 6 years of age and older for the eosinophilic asthma. And then for the preferred brand drug list updates, for additions to brand preferred, we have Durezol and Rectiv and Thiola. And then for removals, we have Delzicol, Livalo, and Noxafil. And then as FYI for vaccines, Ixchiq, which is for the chikungunya virus. I had people daring me earlier because I was singing this song to the Macarena around the chikungunya virus, but then I found out it was really deadly in India, and that seemed a little sad, so I changed it to the Chiquitita by ABBA song instead with chikungunya, so you can sing that later to yourself. We're recommending adding to coverage with age limit of 18 years of age and older, and a quantity limit of 1 dose per lifetime. And then that would be for the non-VFC pharmacies. For the VFC pharmacies, Abrysvo, updating minimum age to 11 years of age, and then Ixchic's adding to coverage with an age limit of 18 years of age or older and a 1 dose per lifetime. Any questions on new business?
Are you going to talk about the respiratory and allergy biologics that was sent?
That we did on the last page.
Yeah, that was around the Fasenra
Okay.
update to the.
Well, I had one question about those, and that most of them is that they were utilizing one of the following inhaled asthma treatments for 90 of the past 120 days. And wouldn't we want to put in there that they're using them every day, because the 1 month they're not using them, they have maybe asthma problems and they go to the emergency room, and they or get admitted, and it's because they're not using the inhaled corticosteroids. So we reward somebody for bad compliance.
So the reason we choose 90 of 120 is to one, allow for any fluctuation in potentially when they filled it, as well as if there was some situation where maybe they had extra from a previous time. So it's just a systematic look back to try and look for some level of compliance. I mean, we can certainly tighten it up. We just end up sometimes where then when we make it too close or too tight and people, you know, maybe are off by a little bit here or there, then we're rejecting additional claims. So we've kind of always historically used 90 of 120 to kind of look for a measure of compliance. But I mean, I do understand what you're saying, but a lot of times it's not as straightforward as they didn't use it for 30 days straight. Usually it's maybe they were 5 days late or 7 days late one time and then another 7 days late. Not that that's great compliance either, but they are still kind of regularly utilizing.
Well, I mean, if it's getting checked for regular use, I'm good with that. I see what you're saying, but it would just seem, you know, these drugs are not cheap, and that if somebody then doesn't use it for 30 days, and then they got ER visits and admissions, we're kind of rewarding them.
I don't disagree with what you're saying, and I'm not going to say that theoretically that couldn't happen or hasn't happened in an individual. I don't know that we've noticed that historically. But
could
again,
we add compliance is verified, something like that, to that, so it's looked to make sure that they have been?
Well, it's silent off.
I was gonna say it's an automated PA. So, I mean, if you're wanting to really tighten it up, I mean, we have had some where we've done 90 and 105.
Past 105.
That gets a little close for people. I mean, but we have done that historically.
105 out of the past 120 days?
We've done 90 days in the past 105 days.
Oh, 190 of the past 105.
So basically,
well, that might be better. I think that would be better than 120.
TR, this is John. So we have the 90 of 120, and the MCEs also utilize that, and it's not just on this one, it's on another number of them. So, but your point is valid, and I was wondering if you might allow us to kind of look at the, you know, the drugs with this kind of 30-day window, and maybe take a across-the-board look, even in MCE land, to see if that's creating issues, or if it's not, and then come back to you. And then if it is an issue where we need to tighten it up, then we could do it. Like, would you allow us to maybe take a look at it first and come back?
Well, yeah, that would be fine. Or say for 90 of the past 120 days, and compliance was reviewed, versus just it passed, you know, drug filling.
I think a lot of the MCEs will use accumulated on hand with their refill. So what could if you do it that tight, what's going to happen is somebody's going to miss by a day, and they will be compliant. It's just that they calculate an on hand value cumulatively. So I think it's going to cause more problems than it's going to probably solve, because it's going to reject on people that are compliant that just miss it by a small amount of days. Well, I mean, we can look and see if it's an issue, but I think the problem is the tighter you get, it's going to hit false positive.
Well, I understand, but I mean, it just, if somebody doesn't take it for 30 days and you can verify it, I'm not sure I'd give them these drugs, because they're just basically non-compliant. But it's up to you guys. I guess saving a hospitalization, I don't know, are these drugs cheaper than hospitalizations? I guess that's what's got to be looked at, but that's a pretty big window when I saw that.
They are cheaper than a hospitalization. I can answer that right off the bat. But the other thing too is, as far as verifying compliance, it's because they're automated, we would then have to kind of reject almost everybody to look at their compliance, which would then kind of, potential cause gaps in therapy, et cetera. So I do think taking a step back and looking at it and then coming back
Okay.
to you with some.
That's
would
fine.
probably be-
Okay. All right. Thanks.
Thank you. Any other questions or comments? If not, if I could get a motion and a second for that, with knowing that we will bring back some information on the 90 and past 120 at our next meeting.
I move to approve. Dr. Marshall.
All right. I have a motion and a second. So Dr. Marshall,
Aye.
Dr. Class,
Aye.
Ms. Fippen,
Aye.
Dr. Ott,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams. Thank you. We have all ayes, so that motion will carry. Any other new business that you all have for us today? All right, I'm hearing none. So Dr. Marshall, that takes us to the last item on the agenda of adjournment.
Adjourned. Thank you.
Thank you, everybody. Have a great weekend.
You too.
See you next month.
Bye-bye.
Thanks. Bye-bye. All right. Thanks, you too. What are you looking for?
Should we try to chat with them? What do you, I mean, as far as evaluating this, the allergy biologics? You think just looking at members that